Welcome to This Explainer. Okay, today we're unraveling a really intense, high-stakes medical mystery. Imagine a scenario where a perfectly healthy, young adult suddenly crashes, spiraling into life-threatening respiratory failure in just a matter of hours. It's a terrifying clinical picture, and finding the culprit? Well, that requires some incredibly sharp scientific reasoning. So, let's explore the science behind one of the most deceptive and rapidly deteriorating infections out there.
Now picture this. A previously healthy 28-year-old guy comes in with 4 days of fever, severe muscle aches, and a headache. Suddenly, his shortness of breath just rapidly worsens. His blood pressure drops into hypotension, his oxygen levels plummet into hypoxia, and as you can see on the x-ray, he has bilateral pulmonary infiltrates. Initially, this mimics the stuff we see every single day, right? Flu, COVID-19, bacterial pneumonia, sepsis, but within hours, he's in complete respiratory failure, requiring an ICU admission. So what exactly is happening here?
The diagnosis is Hantavirus pulmonary syndrome, or HPS. This is the absolute definition of a classic, rapidly deteriorating missed zoonotic infection, and it carries a staggering case fatality rate. It's absolutely crucial we recognize this early, because intervention is often the literal only thing that can save the patient's life.
Okay, let's dive right into this and look at the actual science of hantavirus.
So, hantaviruses are RNA viruses belonging to the Hantavirus family. And their primary transmission vectors? Rodents. But here's the catch. You don't even need a mouse to bite you. The virus actively sheds in rodent urine, feces, and saliva. Through desiccation, those viral particles become aerosolized in contaminated dust. We just breathe in that invisible pathogen as accidental hosts. Also, it's worth noting that human-to-human transmission is extremely rare, pretty much only seen in a few specific South American strains.
Now, looking at the science here, the core pathophysiology is immune-mediated endothelial dysfunction. The virus exhibits tropism for your endothelial cells, meaning it targets the cells lining your blood vessels. But surprisingly, the virus itself doesn't actually cause massive tissue destruction. Instead, it triggers this massive hyperinflammatory cytostorm. It's the host's own overactive immune response that causes those endothelial cell barriers to literally pull apart.
Let's track this cellular cascade visually. Step 1, we have the endothelial infection. Step 2, that aggressive immune response kicks in. Step 3, massive capillary leak. And step 4, distributive shock. Picture this at the microscopic level. Those tight junctions completely fail, causing massive fluid extravasation. Basically, all the fluid inside the blood vessels leaks right out into the surrounding tissues. In the lungs, this triggers massive non-cardiogenic pulmonary edema. The patient's lungs literally fill with their own fluid, not because of a failing heart, but because of a failing cellular barrier.
Now, what's really interesting about this next part is how this presents in two major syndromes.
Yeah, so this exact same mechanism of capillary leak we just mapped out, it manifests completely differently depending on the viral strain and the geography. On the left side of the screen, we have Hantavirus pulmonary syndrome, or HPS, found primarily in North and South America, famously caused by the sin nombre virus. The main target organ? The lungs, which leads to that massive pulmonary edema. But on the right, we have hemorrhagic fever with renal syndrome, or HFRS. This one is found mostly in Europe and Asia, caused by the Hantavirus and Pumala Here, you still get the capillary leak, but the dominant feature is severe renal injury and bleeding. So, same viral family, but completely different primary organ targets based on where you are in the world.
So, how do we catch this? Let's get into the clinical reasoning framework.
Take a close look at this timeline mapped out here, specifically how abruptly things shift at day 5. Day 0 is that invisible rodent exposure. Days 1 through 4 represent the viral prodrome. Now, this mimics the flu, right? Fever, malaise, abdominal pain. But your critical clinical clue here is severe muscle aches, or myalgia, that are totally out of proportion to a normal flu. Then, damn, we hit day 5. Sudden cardiopulmonary collapse. The patient abruptly transitions to severe coughing, dyspnea, hypoxia, and shock. Finally, day 6 is when the labs and confirmation usually catch up.
And speaking of labs, these classic findings are what definitively distinguish hantavirus from your typical bacterial pneumonia. Notice the early thrombocytopenia. Platelets just plummet as they get consumed by that damaged endothelium. Then we see hemoconcentration. Since the fluid is extravasicating out of the vessels, the red blood cells left behind become highly concentrated. You're also going to see a high white blood cell count, elevated lactate from the resulting shock, and abnormal liver enzymes.
You really have to listen closely to the patient's history. If you ever hear someone say, "I was cleaning an old shed," or maybe a dusty barn or a cabin, and they now have a fever and severe muscle aches, warning bells should immediately go off. This specific hidden exposure history is the ultimate clue.
A young healthy person plus a history of cleaning an old shed, that equals hantavirus until proven otherwise.
So the crucial point is how we manage this and the fatal mistakes to avoid.
How do we actually manage this and keep the patient alive when they start crashing? First, we rely on the ABCs: airway, breathing, circulation, which means early oxygen and early ICU referral for potential mechanical ventilation. Second is hemodynamic support. Because they're in shock, they might need vasopressors. In the absolute most severe cases of HPS, ECMO, which is essentially an artificial lung bypass machine, might actually be life-saving. For HFRS, there's some evidence for using the antiviral ribavirin early on, but for the pulmonary syndrome, there is currently no proven specific antiviral benefit. Finally, you confirm the diagnosis with serology or a PCR test.
But managing this leads to a pretty terrifying, delicate paradox. And here's the fatal mistake. When a patient is in shock with low blood pressure, the standard medical reflex is to push aggressive IV fluids, right? But remember the cellular science we just covered. If the patient has a massive capillary leak, fluid resuscitation will literally pour straight into their alveolar spaces. You will drown the patient and drastically worsen the pulmonary edema. Fluids have to be given incredibly cautiously.
To summarize this whole critical clinical picture, you need to memorize this red flag combo: a fever, plus thrombocytopenia, plus a history of rodent exposure, plus rapidly worsening hypoxemia. If you see this deadly combination, it mandates immediate ICU referral. Do not wait around for the sudden cardiopulmonary collapse to occur.
All right, let's lock this in with a hand-to-memory system.
To ensure you instantly recognize and logically map this disease in the future, let's actually map it to the word Hanta, and this brilliantly illustrates what's going on scientifically. H is for hypoxia, that rapid drop in oxygen. A is for aerosolized rodent excreta, our invisible transmission vector. N is for non-cardiogenic pulmonary edema, meaning the lungs are filling with fluid but not because of the heart. T is for thrombocytopenia, that early drop in platelets being consumed by the damaged vessels. And finally, A is for acute capillary leak, which is the underlying immune-mediated mechanism driving the shock.
So, I'll leave you with this question. If a patient says they were cleaning an old, dusty cabin last week, and today they have a fever, severe muscle aches, and dropping platelets, what is your very first move? I really hope this explainer has empowered you with the scientific vigilance to know exactly what's happening under the surface, why that sudden crash is imminent, and exactly how to catch this deadly zoonotic infection before it's too late.